Welcome to Clear the Air with me, Angela Lim, medical doctor and co-founder of ClearHead, an innovative employee wellbeing platform. Clear the Air is a podcast covering those experiences in your life or questions you have that you feel too vulnerable to share with those around you, such as, why do I feel so lonely? And what can I do to feel happier? We get real and raw on these existential questions on mental health and well-being that's puzzled humans for millennia, sharing the science behind what you're experiencing and the answers behind those questions. The human brain is an incredibly complex organ. We are all wired to process emotions, thoughts, and behaviors differently due to a range of factors including our genetics and the environment. However, sometimes our brains don't quite work the way we expect it to, and this can lead individuals to either develop serious mental health disorders such as schizophrenia and bipolar disorder, or be considered neurodivergent with conditions such as autism or ADHD. Our guest today is an expert in helping us unpack all the nuances behind diagnosing mental health disorders and the best way to manage them. Professor Marie Bismark is a psychiatrist, public health physician, and health lawyer. She divides her time between New Zealand and Australia, and in addition to her clinical work, Marie leads a research team at the University of Melbourne, focusing on the interface between patient safety and clinician well-being. She serves as a director of several health sector organizations, including the Royal Women's Hospital and Summerset Aged Care. Marie completed a Harkness Fellowship at Harvard, and her research has influenced regulatory policies in Australia and internationally. Welcome, Marie.
Thank you so much for inviting me along.
Amazing. Well, one of the things that we find often is in the sort of public education space is very much in that mild to moderate parts of mental health. And I think to start us off, maybe you can define for us what are mental health disorders, and then we can maybe go into the more complex mental health disorders that exist.
Yeah, that's a great question, because as humans, we all have really complex emotions. It's very normal for people to feel sadness or worry or excitement, or to feel put out if some of their routines are disturbed. I think those are all very normal human emotions. And where things cross over into a mental health disorder is where it's starting to impact your functioning. So at the point, if you think about depression, at the point where your feelings of sadness or loss of energy or poor sleep are affecting your ability to do the things that you care about, if they're impacting your ability to work or your functioning at home or with your family or your relationships with your friends, it's when we see that impact on social and occupational functioning that something begins to cross the line from a normal human emotion over into a mental health disorder.
And one of the common, more complex mental health disorders is schizophrenia and bipolar disorder. Would you like to kind of give us a little bit of a sense of what those are, especially in the context of someone who might be figuring out whether they have schizophrenia or maybe someone who might be supporting someone who does?
Yeah. Well, we have lots of people who've joined us today and others who are listening online, and I think there'll be quite a few people in our audience who either know and love somebody who has one of these serious mental disorders, or perhaps has the experience of living with schizophrenia or bipolar disorder themselves. So probably 2 to 3% of the population will have one of these serious mental health disorders, and schizophrenia and bipolar are two of the more commonly known ones. So if we think of bipolar disorder first, it's characterized by episodes of depression. And in fact, many people with bipolar disorder will have more and longer periods of depression than the episodes of mania. But the thing that really characterizes bipolar is that you do have these episodes of mania where people will typically have more energy, they'll be sleeping less, they'll be talking more, they can feel very creative. And in the early stages of what we call hypomania, that can actually feel fantastic, that people may feel that they're really productive, that they're able to write or create music or come up with new business ideas, that their brain is firing really quickly. They can have enormous energy and productivity and not need much sleep. And that can feel pretty good, those early stages of hypomania. But then it will progress into a state of mania where things become more difficult for patients. So, for example, they may become impulsive or reckless. So if they think they have a great new business idea, they may spend a lot of money on an idea. Or if they think that they're a brilliant artist, they may give up their job in order to follow that creative pursuit. And so during those periods of mania, people can actually lose a lot. You know, they can cause tremendous damage to their relationships and their finances and their occupational functioning. So we sometimes see that as people are recovering from an episode of mania, they're often coming to terms with some of the decisions that they made. So it's not uncommon to see that people may be driving too fast. They may end up with convictions for speeding, or they may be gambling away a lot of money or engaging in impulsive sexual behaviour. So, you know, those are the episodes of mania where, you know, you'll see this reduced sleep, increased energy, impulsive risk-taking behaviour, and then that will alternate with periods of good functioning where people feel like things are pretty normal. And then, as I said earlier, people with bipolar disorder will commonly have episodes of depression, which can be very severe and quite difficult to treat. But the good news is that there are great treatments available for bipolar disorder, and lithium is a very, very old treatment, but it's still one of the most effective ones that we have available. And lots of things that people can do around their lifestyle as well to help manage their bipolar. So in my clinical practice, I look after lots of very, very high functioning people who are working as lawyers or health practitioners or in business who have bipolar disorder, who are functioning at a very high level and whose illness is well controlled. And then when we think about schizophrenia, I guess the defining feature of schizophrenia is that people begin to have difficulty figuring out what's real and what's not real. So people with schizophrenia may develop delusions. A pretty common delusion is a paranoid delusion, where they may be worried that people are following them or talking about them, or that they're being watched or threatened in some way. So that false belief, which is often paranoid in nature. People with schizophrenia can get hallucinations as well, which are most commonly auditory hallucinations. So people are hearing voices, which can sound just as real as you and I talking in the room here today. And it can be very distracting and difficult for people to function if they're constantly hearing voices, which can sometimes be telling them to do things or can be very critical or commanding. And then another feature of schizophrenia is that people can get what we call thought disorder, where their thoughts are not as clear or as organised as they would usually be. And if you're listening to somebody with thought disorder, it can be quite difficult to follow what they're saying. So those are what we call the positive features of schizophrenia. But then there are also what we call the negative features, which can be very disabling. And the negative features of schizophrenia involve a loss of interest in activities, difficulty with motivation, sometimes some social withdrawal. And what we find is that even when we've treated the active psychosis, so if somebody no longer has the delusions or the hallucinations or the thought disorder, they may still struggle with that loss of energy and loss of social functioning. But again, there are treatments available. Unfortunately, there are no perfect treatments yet. They all carry some side effects, but again, people can live a really high quality life with well-treated schizophrenia.
And I think that's probably one of the most important things that you've been able to, in some ways, myth bust, is that that people can have quite high functioning lives if they are able to manage their condition. You obviously mentioned medication as one part of the management process. When you think about management, treatment plans, how do you know when you need to start medication versus, maybe is therapy sufficient or lifestyle changes in the context of these more complex mental health disorders?
It's a great question. Most research shows that people will often have the best outcomes when they have a combination of all three. So a combination of medication and therapy, and also attention to some of those lifestyle and social and environmental factors. In some situations, it will be reasonable to try therapy first. So, for example, if somebody has a depressive illness, it may be that we can use some behavioural activation or other modes of therapy to help them. Usually by the time that somebody has developed psychotic symptoms, so delusions or hearing voices, we would typically be looking to medication to help treat those symptoms, but also combining that with the other supportive modalities as well, because we know that for both schizophrenia and for bipolar disorder, the context in which people are living can really aggravate their symptoms. So I see the enormous difference that if somebody has, for example, been homeless and then we're able to find them secure accommodation, how much the symptoms of their serious mental illness will reduce once they have a safe roof over their head. You can understand that if you're living on the street, that feelings of paranoia and being unsafe would understandably be much worse. So really paying attention to social connection, financial stability, housing, relationships, people having purposeful things to do during the day is such an important part of treating those serious mental illnesses as well.
And, you mentioned a whole range of things, including housing, financial situations. And what's the best way to handle that in the context that maybe that's not as accessible for some people? For example, they might just be born in a situation of poverty and have not been able to get themselves out of the poverty trap.
Yeah, that's right. And as well as being a psychiatrist, I'm also a trained public health physician. And I think it's so important for us to look upstream at some of those social determinants of health. So we know, for example, that people's childhood experiences can increase their risk of developing these serious mental illnesses. So if you suffer a lot of childhood adverse events, whether that's poverty or trauma, or significant loss or abuse during childhood, that increases your risk of going on to develop schizophrenia or bipolar disorder. So I always think that within the mental health sphere, we could do much better at thinking about some of those upstream determinants of health. And also this idea of health in all policies, that if you're wanting to improve mental health, you do also need to be thinking about education and employment and housing and domestic violence, and nutrition and all of those other aspects that don't traditionally fall under a mental health portfolio.
And you sort of briefly alluded this about the childhood trauma being a trigger potentially for someone to develop schizophrenia. When you look at the causes of these mental health disorders, is it just genetic? Is it environmental? How do we unpack why someone develops a mental health disorder versus someone who doesn't?
Yeah, that's a great question. So some mental health disorders are more strongly genetic than others. So bipolar disorder is a very strongly genetic condition. But even so, if you take identical twins and one identical twin has bipolar disorder, even though the other twin has identical genes, they're not always going to develop bipolar disorder, although they will be at a much higher risk of it. And I think we're going to go on and talk about ADHD later. But again, if a child has ADHD, there's about a 50% chance that one of their parents will also have ADHD. So again, a very strong genetic influence, but it's both nature and nurture. So certainly genes play a role, but those environmental conditions, which can start even before birth, can play a role as well. So, for example, with ADHD, it's closely linked in some small group of patients with exposure to alcohol during pregnancy. So if a child has fetal alcohol spectrum disorder, then they'll also be at increased risk of developing ADHD. And then we also know that exposure to trauma can affect people's executive functioning, which can overlap with symptoms of ADHD. So I think it's really both nature and nurture.
Mm. So you sort of talked about, when you would consider a mental health disorder something that you need to do something about. It's when it's really starting to affect your functioning and your life. And you sort of talked about some of the common treatments for schizophrenia, bipolar. When you think about either as the individual recognizing that they might need some help or someone who is a loved one noticing that something's not quite right, generally, what would you say is a good first step to move towards that management process of being able to stay well in the community?
Yeah, so one of the challenging aspects of some of these serious mental health disorders is that as part of the illness, people can lose insight. So when somebody's experiencing an episode of mania or psychosis, they may not recognize that they're unwell. And as I said earlier, sometimes those early stages of mania can actually feel quite good for people, and they may be very reluctant to seek help. Or if somebody has paranoid delusions, they'll feel very real to them, and they may feel as though people are criticizing them or not believing them if they say that they're being followed or threatened and people tell them that they have a mental illness. So that can be a really difficult line to walk. And I'm sure there are some people who are listening today who've been in that position of trying to support somebody with a mental illness who doesn't recognize that they're unwell. I think often the best thing to do is to meet people where they're at and to understand what is causing them distress and what they would like to change. So, for example, if somebody is having paranoid delusions, I wouldn't tell them that they're wrong or that I don't believe them or that they're delusional necessarily. I would try to understand what their experience is, what the impact of that is on their life, the kind of distress that it's causing them, and see if we can approach it from that way. So sometimes it's even possible to say, look, you're clearly really distressed, you're not sleeping well, this is affecting your relationship with your friends and family. Let's see if we can try and help with some of those things, rather than necessarily trying to contradict their beliefs head on. You try and identify some of the things that they might like help with and start there. And I think it makes an enormous difference if you've got a relationship of trust with a health practitioner. So this is why I always recommend that people have a regular GP. I think it's much easier to have those hard conversations about whether somebody is becoming unwell and might need some help if they're talking to someone who they know and trust. So a GP is often a really good starting place to begin having those conversations. But unfortunately, sometimes people will become so unwell that there will be a risk to themselves, for example, through suicidal thoughts, or there may be a risk to others. So if someone's very paranoid, they may feel that they need to defend themselves and may begin to carry weapons and behave in threatening ways to others because they're feeling frightened and paranoid. And in those situations, we do have access to Mental Health Act so that we can require compulsory assessment and treatment, but that's always a last resort, and we always try and work with people as voluntary patients first if we possibly can.
Yeah, it's always very tricky when people don't have the insight to kind of get them to be open and ready to receive help. Are there, I guess, investigations that can be done that is really black and white and helps the individual recognize they have a problem. So for example, if you have a heart attack or if you have a stroke, there are investigations you can do that shows like, oh, here's an MRI scan of how a part of your brain did not have blood supply and therefore it's dying. Do we have investigations that people can do in the context of mental health disorders?
It would be so nice if we could do that testing and know for sure what somebody's diagnosis is, but unfortunately psychiatry is still quite an inexact science. There are certainly researchers who are able to do what we call functional MRIs, where you can see the blood flow to different parts of the brain and different ways of thinking and ways of perceiving the world, and so you can see differences. And at the genetic level, there's really interesting research done about the genes that predispose people to serious mental illness. But in ordinary everyday practice, we're still very reliant on talking to people, observing their behaviour, getting information from friends and family, and really relying on their symptoms and the way that they're presenting. And often it takes time to make a diagnosis of a serious mental illness as well. So, for example, a not uncommon situation is where a young person has been using a lot of cannabis. They may become paranoid, begin hearing voices, and develop what we call a first episode psychosis. So it's not possible for us to say at that point in time whether this is just going to be a one-off drug-induced psychosis or whether the young person may go on to develop schizophrenia. So sometimes in psychiatry there is a bit of watching and waiting. And similarly, if somebody has a depressive episode, if, for example, they have a sister or a parent who has bipolar disorder, we might have a really high level of alert for the possibility that they may go on to develop bipolar disorder. But until they have that first manic episode, we can't say for sure that they do have bipolar disorder. So we are often watching and observing and supporting people as best we can while we wait for the diagnosis to declare itself.
And I guess because, as you said, it can be a bit of an inexact science, how does one sort of know when to plot the individual on the spectrum? How do we know when we kind of say, okay, you're a moderate case and you're a severe case, and obviously depending on the severity, you would escalate the treatment plan accordingly. So how do you think about that in that context?
So there are patient-driven outcome measures where often as part of our treatment, we'll be asking people what really matters to them and what being well looks like in the context of their own lives. So I think that's a really helpful thing to do. And for people with a serious mental illness, having a wellness plan that describes what they look like when things are going really well for them, whether that's connecting with friends and family or being able to engage in employment, sleeping well, having positive thoughts about themselves. And then people can identify, I guess, if you think about a traffic light system, an orange light and a red light for when we're seeing these early warning signs of deterioration and when someone is really unwell. And one of the things that really worries me with the shortages in access to mental health care is we're often not seeing patients until those red lights are flashing. Whereas if you are able to identify the early warning signs, it's so much easier to treat somebody and to help them to return back to a high level of functioning. And it really worries me when we end up with this crisis-driven model of care where it's not until somebody's a risk to themselves or a risk to others or severely unwell that they're able to access mental health services. And again, if we think about the example of bipolar disorder, if I have a patient who I know well who has bipolar disorder and they say to me, look, for the last 3 nights, I've really been struggling to get to sleep. I've been writing lots and I've got all sorts of ideas for projects that I want to be doing. I'm feeling really creative, lots of energy. My family tell me I'm talking too fast. As soon as we begin to hear those early warning signs, if we can just gradually increase their medication, make sure they get a few nights of really good sleep, try and stabilize things in their life, we can often avoid a hospital admission. But if they don't have a relationship of trust with a psychiatrist or a GP, then things can deteriorate to the point where we may need to do a hospital admission, sometimes even under the Mental Health Act. And that's an awful outcome for the patient, for their family, and it's not the way that most clinicians want to work either. I think we'd all much prefer to be doing the early intervention work if we can.
Yeah, absolutely. And I think that's the premise behind why we started Clearhead, is seeing that we are driven by a crisis model and that early intervention is a huge predictor of a better clinical outcome, including suicide prevention. So 100% support that. And obviously Clearhead is an EAP for companies that provide that to their employees. And that means being able to access both self-help tools that help you build self-awareness so that you can start to, build some insight around what your early warning signs are, what are your triggers, but then also being able to access therapy to prevent people to get to that crisis point. That makes sense. When you think about this idea of people sharing with you their symptoms, etc., it really, in some ways, as you said, requires them to have that insight. What happens if someone is aware they are unwell, but they are not wanting to be maybe honest with what's actually really going on, because they have been in the system enough to know, oh, if I say this, then I'm going to end up being admitted into the hospital. And so as long as I don't say this, but I am truly being paranoid right now, but I'll just not tell them that. I'll keep really quiet. Is observational skills and is secondhand account from family and friends sufficient to support individuals in that context?
I think that information from family and friends is so important, and also in encouraging somebody to receive treatment, that if you can identify the person in the family who they trust and who they really believe has their best interests at heart. So sometimes I'll have patients who'll say to me, for example, I don't think I'm unwell, but my fiance is really worried about me, and I know that she cares about me and has my best interests at heart. So if my fiance is worried about me, then maybe I need to do something. And so you'll see people sometimes who don't have insight, who don't feel unwell, but if they have a relationship of trust with somebody in their family or with a treating practitioner, you can still kind of get the door open enough to begin providing some treatment. But certainly there are some situations where people just completely lose insight, and it can be frightening for family members, especially if it's the first time that they've seen someone with a full-blown psychosis or a full-blown manic episode. And that's where every region of Australia and New Zealand will have a crisis mental health number who you can call. They can usually give you advice over the phone, and they'll very often come and do a home visit to be able to come and assess the person in their familiar environment and try and make an assessment of whether a hospital admission may be needed.
We've talked a lot actually about the role of family and friends, loved ones in the individual's journey. Is there anything we should consider in terms of supporting those who are supporting the patient?
Yeah, absolutely. I think we could do so much more to be supporting carers and family members. And sometimes those carers will be children. So there are amazing organisations set up to support the children of adults with mental illness, because it's really tough. If you're 12 or 13 years old and mum or dad has become really unwell and you're trying to go to school, but also keep an eye on a parent and you're worried about them and perhaps trying to figure out how to reach out for help. So, caregivers are not always going to be capable adults. They may sometimes have some of their own needs as well. And I think that there is so much more that we could be doing. I really wish that there were more hospital in the home services available, because carers do so much at home. And I think having clinicians being able to come in and support people at home can make a big difference as well. And we need to recognise that, for some people with a long-standing severe mental illness, they may not have that strength of social relationships. So having a chronic illness, people can end up quite socially isolated. Sometimes periods of illness can harm their relationships with others. And so we do see some people who are really quite lonely, and that's where peer support organisations can play an incredibly important role in helping those people to find forms of social connection.
And, I think it's a good way to kind of potentially transition to the second half of this chat, which is maybe this context about neurodivergence. So maybe you can share with us, what is neurodivergence? Is it a mental health disorder? Is it not? How would you define it?
Yeah, so I think the two forms of neurodiversity that most people are familiar with are autism and attention deficit hyperactivity disorder. There's a bit of controversy really about whether the language of mental disorders is appropriate or not. They are developmental conditions usually, which means that they have their onset in childhood, although there are some situations, for example, if somebody suffers a brain injury later in life, they may develop ADHD after a brain injury, but on the whole, they are thought of as neurodevelopmental conditions, which means that the symptoms start in childhood. And there's actually a surprising amount of overlap between autism and ADHD. So with both autism and ADHD, people can have sensory issues. So finding that things are too loud or too bright or overwhelming. With both conditions, you can get this real hyper focus. And for some people, that's a real strength. You sometimes hear about these neurodiversity superpowers and that ability to hyper focus and just dive really deep in a topic and immerse yourself in everything about it. And work on a project or learn about something for hours on end can be a real strength for some people with a neurodiverse brain. There can be some social interactions can sometimes feel a bit more challenging, both for people with ADHD and with autism, and you can get some executive dysfunction with both conditions where the process of planning and thinking ahead and making judgments can be difficult. I guess some of the differences are that with people with autism spectrum disorder, it'll be more common to see some rigidity, often a preference for strong routines or things being done in a particular way, liking to have certainty and sometimes experiencing anxiety if there are unanticipated changes, perhaps being very aware of things that others may not notice or taking things quite literally. And then with ADHD, you see more of those impairments around planning and executing tasks and following things through. So problems with forgetting about appointments or procrastination or making careless mistakes or forgetting instructions that they've been given or losing things. But again, there are real strengths to neurodivergent brains as well. So some of my patients who have quite severe ADHD are just fantastic in a crisis, that their brains are really great. When something needs to be done and needs to be done quickly and it requires their full focus, they can be amazing in a crisis. But then the next day when they have to write up all the paperwork related to that crisis situation, that can be really challenging for them. So I think certainly for employers, there are huge benefits to having diversity of thought styles within your workforce. But a lot of it is just really understanding how to bring out the best in the people who work for you. And we often like to say that things that employers can do to support people who are neurodivergent will often be really helpful for other employees as well. So things like giving people some control over the environment that they're working in, whether that's noise cancelling headphones or ability to adjust the lights or the temperature, asking people what their preferences are in terms of how best to communicate with them. Some people might prefer really clear written instructions. And then giving people some flexibility, the ability to attend medical appointments when they need to, and asking people which aspects of their job they enjoy the most and really trying to create roles that bring out the best in them. And as I said, all of those things are things that probably benefit all employees, as well as those with autism or ADHD. That, for example, if you've got somebody who really likes routine and structures and has great attention to detail, you may be able to craft a role that benefits from those qualities. Whereas if you have somebody who thrives in a crisis, wants to be in a busy, active job, they're probably not going to want to do those same very detail-driven, routine-type activities.
But you then, as you said, because we are not classifying these as mental health disorders, would it still be relevant to kind of think about it in the context of medication, therapy, lifestyle changes? How do you think about those three aspects of management in the context of neurodevelopmental disorders?
Absolutely. So for ADHD, we have very, very effective medications. So out of all of the medications that we use in psychiatry, the use of stimulant medications for ADHD are some of the most life-changing medications that we have available. They often work very quickly and can make tremendous changes to people's social and occupational functioning. I'm sure that many people on the call today will either themselves or a child or a loved one will have been diagnosed with ADHD, and they will see the difference that it makes to have that diagnosis and have appropriate treatment. But we always say it's pills and skills. It's not just pills. You need to be thinking about those skills as well to help support your executive functioning, to understand yourself, your sensory preferences, the way in which you think and work best, the way in which your ADHD might affect your social relationships, and being really proactive about trying to optimise the conditions in which you live to support you to flourish and to support the way that your brain works. So for ADHD, stimulant medications like Ritalin or dexamphetamine are usually the first line treatments, but there are non-stimulant options as well, which can be very effective for some people. And it's interesting that for some people who are diagnosed with ADHD as adults, they notice how much their anxiety reduces, that previously they may have been diagnosed with an anxiety disorder, but it turns out that a lot of their anxiety was related to the executive functioning struggles that they were having. And once they're no longer procrastinating or struggling to initiate and complete tasks, a lot of their anxiety can drop away once their ADHD is treated. When it comes to autism spectrum disorder, the approach is generally much more focused on, therapy and skills, behaviour and environmental factors. There are fewer medications that we use. There are some medications. So, for example, if somebody with severe autism spectrum disorder is having real difficulty in regulating their emotions and having aggressive outbursts, we might use very low doses of antipsychotic medications, but generally there's less of a role for medication in autism than for ADHD. But there are lots of things you can do to help optimise people's functioning, things like having routines, and that if one of those routines is going to change, giving people a heads up before that change happens. Occupational therapists are fantastic at doing sensory assessments to try and optimise people's sensory environments. And that's often a real balance between not being overwhelmed but not being understimulated either. And it helps enormously when you have a really good sensory profile done to know what kind of environments are going to optimise your functioning. And again, as we mentioned earlier, the support for caregivers is really critical.
Well, Marie, you kind of opened a can of worms, which is to kind of allude that sometimes these diagnoses might not be accurate. So someone who was diagnosed as anxiety was actually underdiagnosed for ADHD. How do we think about that in the context of, you said, there's not like some clear investigation that can be done for every mental health disorders that are out there? Yeah.
So there's a whole field of study around diagnostic certainty and the way in which we classify and think about mental disorders. And some people say that actually these diagnoses don't make sense at all, that we should only be thinking about the kind of symptoms that people are experiencing. I think from a clinical perspective, it's really important to keep an open mind. And one of the things that can cause a lot of harm in medicine is this idea of premature closure, where you make a diagnosis and then get really fixed. You know, the doctor and the treating team can become really fixed on a diagnosis and stop having an open mind about what else might be going on. And certainly with mental disorders, we know that there are a number of physical conditions that can contribute to mental health symptoms. So if somebody's got low mood and very low energy, it might actually be that they're iron deficient, or that they have low thyroid hormones, or that they have a B12 deficiency. And so I think it would be too easy to kind of just say that you're depressed and actually overlook the fact that there may be physical health conditions that are contributing to this person's mental health symptoms. So I think it's so important for all of us working in mental health and for people supporting those with a mental health disorder to really keep an open mind about what's going on. So you want to avoid this premature closure where you come to a diagnosis too soon and become really fixed on it. But you also want to avoid what we call diagnostic overshadowing, which is where if somebody with a mental illness presents with some physical health symptoms, diagnostic overshadowing is what occurs when all of their physical health symptoms get written off as being due to their mental health condition. So, for example, if a 60-year-old woman with a history of anxiety goes to the emergency department and says that she's having chest pain and is short of breath, she might be told that it's anxiety and that she's having a panic attack because she's got a known history of an anxiety disorder. But actually, for a 60-year-old woman, you know, there's a very real possibility that she might be having a cardiac event. And it's really important that she gets appropriate care in that emergency department. And perhaps she needs an ECG or other blood tests to see if she is perhaps having a cardiac event as well. We know that people with severe mental illnesses have a life expectancy that's about 17 years shorter than people without a serious mental health disorder. And I think that diagnostic overshadowing and lack of attention being paid to physical health conditions contributes to that reduced life expectancy.
Absolutely, and I think that speaks to the complexity of medicine, but also the need to always keep an open mind. And if you feel something's not right, you know, keep advocating for yourself or for your loved one. And that's something that, unfortunately, I have also seen in the hospital, where what you've just said end up meaning that someone needed to go to hospital when they could have been managed earlier in primary care, for example. And you sort of, I guess, briefly alluded to this, is this concept of comorbidity, which is that actually, you know, life isn't that simple. Sometimes it's not just like I have this one clean diagnosis. It might be you have multiple diagnoses. Is there, I guess, extra consideration that needs to occur for example, people who have neurodiversity, more likely to experience mental health illness like depression because they're living in a neurotypical world and they're constantly having to navigate a system that's not set up to be optimized for the way their brain works?
Absolutely. So in the world of ADHD, comorbidities are the norm, not the exception. So about 70% of people with ADHD will have some other mental health condition. Some of the really common comorbidities that go along with ADHD are autism disorder, anxiety, depression, bipolar disorder, tic disorders. There are a whole range, sometimes obsessive compulsive disorder. There are a whole range of mental health conditions that we often see traveling alongside ADHD. It is one of the reasons that I worry about some of these single issue diagnostic clinics. I'm sure that many of you will have seen clinics advertising that they can diagnose and treat your ADHD. And I do worry that that might work for a small group of the population, but it's actually so common for ADHD to be co-occurring with other serious mental health conditions that I think there are real benefits to having a more holistic assessment and being treated within a multidisciplinary team. One of the things that really worries me is that with the cost of ADHD assessments, that higher functioning people who are in employment or may have access to private health insurance may be able to access ADHD diagnosis and treatment, but some of those most in need are not able to access diagnosis and treatment. And so, for example, if we think about people who are in prison, about 1 in 5 prisoners has untreated ADHD. We know that if you can diagnose and treat the ADHD of people who are involved in the criminal justice system, that their risk of reoffending reduces greatly once their executive functioning improves. People who are homeless, substantial proportion of people who are homeless will have ADHD or autism or an intellectual disability. And again, they're often missing out on diagnosis and treatment. So really important issues of equity and access to healthcare that we need to think about.
Also important, I kind of want to also take a bit of a detour, which is in some ways I feel there's also an over-medicalisation of normal life experiences. So it is normal for you to feel anxious when you're doing something for the first time. You know, it's normal to feel a little bit lonely and isolated or depressed if, you know, circumstances have changed and, you know, maybe all your friends left to travel overseas, but you're stuck home. You know, like all these things mean that, you know, life happens, but we don't necessarily have to put a label and therefore you need medication or you need therapy. How do you think about that? I guess in some ways, the over-medicalization of maybe what we consider normal human responses to stresses in life. And also maybe, you know, the idea about therefore people are now less resilient. And then, of course, people tend to think about like using words that, again, normalize it by saying like, oh, I'm really anxious. In sort of a maybe when the term to use isn't anxiety, for example.
Yeah. I love this idea of emotional literacy around our ability to recognize and name our emotions and our physical responses to those emotions in more nuanced ways. And I think that the more that we have language to talk about our experiences and to share those experiences with others, the more we are able to engage in these conversations about what is often a very ordinary part of being human. And lots of tension in the psychiatric community. So, for example, the inclusion of a prolonged grief disorder in our diagnostic manual, you know, like at what point should a psychiatrist say that if you've lost a spouse or lost a child, that what you're now suffering is pathological rather than human grief. So I think there are really interesting discussions around that. There's a great book called Saving Normal. This idea that actually we do need to allow for the fact that, as you say, anxiety and grief and worry and not wanting to do boring tasks, you know, that lots of these things which can be symptoms of mental disorders are also a part of being human, and allowing some grace and some space for that.
That sounds good. And I think, you know, something that is important, I think, in the context of, you know, how life is and being able to ensure that the limited resources that we have is able to be allocated to those who really need that additional support. And as much as we can learn to improve our literacy, improve our ability to self-manage, that sort of frees up the resources as well. And Marie, something that we normally start off with actually is around what made you get into all of this? You know, why did you decide to take this path of being a psychiatrist and all the other things that you've done?
That's a great question. So my very first job straight out of high school was working in a community drop-in centre. And my job was to make cups of tea and sit and listen to people. And I didn't fully realize it at the time, but looking back, I now recognize that many of the people who used that community drop-in centre did have serious mental illnesses. And it was just such an honor to hear their stories and to be a part of their lives and to be able to, you know, in some way make a difference by being there and getting to know them as people and understanding what they cared about and what mattered to them. So I knew from pretty early on when I went to medical school that I wanted to do psychiatry. But life sometimes gets in the way, and I ended up taking a path much less travelled where after our children were born, I stepped out of clinical medicine for 13 years and studied public health and worked as a lawyer. But I always think that there's no learning that's wasted. And coming back and completing my psychiatry training in my 40s, I probably have a different perspective from some of my younger colleagues, but I think it has been helpful. So, for example, if I'm talking to a parent of a teenager who's experiencing a first episode psychosis, the fact that I've raised 3 teens of my own probably gives me a slightly different perspective on the worry and concern that they may be feeling. Yeah, but it's an enormous privilege to work in psychiatry and to build up those relationships of trust with people and to get to know what really matters to them and what recovery looks like for them, and to be able to support them with that. It's hugely rewarding work.
I agree. You know, we've touched on at different points in the conversation about the challenges our public health system faces in terms of resources. And are there real consequences behind the fact that if people could have been seen earlier, that their outcomes would have been different? So, for example, if someone was able to get scans earlier, they might have picked up the cancer at stage 1, not at stage 4, when it becomes metastatic and, you know, now it's malignant versus benign, you know. Do we have that type of concepts we have to consider in the mental health diagnosis perspective?
And we do know that the longer that people live with an untreated serious mental illness, it causes real damage to their brain. So if you have a severe untreated depression or an ongoing psychosis, we can actually begin to see structural and functional changes in the brain. And the longer an illness goes untreated, the harder it is to treat. And so if we do have this crisis-driven model of care where people are not coming into care until much later, A, their illness is much harder to treat, but B, they're more likely to have a really difficult experience with the mental health service. So, you know, I always, you know, contrast the experience of somebody who is able to just walk into a community health clinic to say that they feel like something's not quite right and, you know, that they're feeling unsafe or paranoid or that they're hearing things, and who is able to be seen straight away, compared with somebody whose illness deteriorates to the point where the police are called, they might be restrained and shackled and injected with antipsychotic medication against their will. They may end up in a seclusion room in hospital, and how enormously distressing and frightening that experience is, and how much it impairs their trust in mental health services in future. And I really see firsthand that where somebody has reached out for help and has accessed it in a caring and supportive way that helps them to remain with their family and in the community and to recover at home, that their long-term outcome will often be much better than somebody who has not accessed care until an absolute crisis situation where treatment had to be forced on them.
Yeah, and I unfortunately have seen that as well. So it's really important to really highlight the importance of, if you think that you might be struggling, don't wait years, because that's kind of what we see in the data, that people wait years because of the stigma, etc., before they actually finally reach out for help. There are services like Clearhead that allows you to do it in a stigma-free way. Similarly, if you observe someone who's struggling, you know, it's kind to be able to kind of sort of say to them, you know, I'm really concerned about you. I've been noticing these things. Shall we go together, go together to see the GP, or I can book the therapy appointment for you. Sometimes it's just taking that first step before the pathway begins.
And I think we do need to acknowledge that many people say that they hear this message about just reaching out for help and how distressing it can be that when they do reach out for help, if help's not there, or if they're told that the waiting list is going to be 6 to 12 months, or that they don't meet eligibility criteria. So I think as a society, we really need to think about those messages, and that if we are asking people to reach out for help, making sure that that help is available when they need it.
Totally agree. I guess obviously, we mentioned, for example, EAP programs through workplaces are one way you can provide support as a workplace. You've talked about a few techniques on empowering individuals to be able to live and thrive at work based on their neurodiversity. Are there any other things that you feel workplaces can do in the context that we might not always be able to influence the public health system?
I think one of the things that really frustrates employees is when they get these tokenistic mental health initiatives, that if your workload is completely unmanageable and you feel unsupported by managers and you're constantly working in a state of crisis, to be told that there's a lunchtime yoga class or to be given a link for a meditation to listen to can be intensely frustrating. And there's a lot of focus on individual resilience. But my friend Louise Stone, who's an excellent GP, likes to say that when we're talking about resilience, that even the bounciest ball can't bounce in a swamp. And so I think that for employees, individual resilience is important, and there's a lot that we can do to understand the things that help to keep us well, but we can only thrive and truly be resilient in a supportive environment. And so for employers to really listen to their staff about the things that are causing them distress or worry or leading to burnout, and addressing some of those structural issues is so important as well.
100%. And that's kind of a core part of what we try to push, is that, to consider resilience not as an individual thing, but, something that's a system, organizational wide aspect, which includes, for example, being able to identify what we call the psychosocial risk factors that drives people to be unwell at work, and then actually systematically addressing it over time is super important. One of the things that we love to end on is, what is the one thing that you do, Marie, to help you stay well? What's your one well-being practice?
So I bake a lot. Well, somebody once said to me that I bake the way that other people drink. So I get a lot of joy in feeding and nurturing other people. So anybody who's worked in a mental health clinic with me will know that more days than not, there are, cakes and homemade bread and things being brought along to share, because I do think that nourishing ourselves and nourishing our community is such an important thing that we can do.
Yeah, you would have made for a model medical student. All the baking we always have to do with every rotation. I guess one final question from me, I guess, because you brought it up, is this idea behind nutrition. Are there things that people can do if they can't at this point in time see a doctor or get access to medication, things that is readily available from a nutritional or lifestyle perspective that people can do?
I wish that there was so much more focus on both nutrition and exercise physiology in addressing mental illness. Unfortunately, pharmaceutical companies make a lot of money, and so they can invest a lot of money in clinical trials, and there's less focus put into clinical trials on the benefits of exercise and nutrition, but they do make an enormous difference. And I'll often say to people that things like fish oil, all of those kind of healthy fats that you get from oily fish and avocados and nuts are all so good for nourishing your brain, and that just being outside and that 30 minutes of walking in the sunshine will do almost as much good as any antidepressant that I can prescribe.
I love that you ended it with something as simple as going for a walk in the sunshine, that vitamin D, that will also help you sleep better. And sleep is such a crucial part of, staying mentally well, allows you to clear the toxins in your brain. And so, yeah, I think that what we hope that we share is that it's totally possible to thrive even with a severe mental health disorder in the community, there are steps that can be taken. There are obviously barriers sometimes, and we hope to kind of address them. But at the very least, there are simple things that you can take that doesn't cost any money, that to take that first step and ask for help. That's it for today's episode. If you want to learn more about how Clearhead can support your workplace, or you have a burning mental health question that you'd like us to explore on the podcast, check us out at myclearhead.com and drop us a message. Love our content? Share it with a friend or leave us a comment on LinkedIn, Instagram, or Facebook. Thank you so much again for listening, and catch you on the next one.